Okay, so continuing with preload. So most important factor when we're talking about preload stretching a cardiac muscle is the venous return. And our venous return is the amount of blood returning to the heart. So slow heartbeat and exercise are both going to increase the venous return. So why would slow heartbeat? Because we're increasing the amount of time that the ventricles can go in and fill. So increased venous return is going to help stretch those ventricles and increases contraction and force. So that's basically the Frank-Starling relationship, where if we increase the venous return, we're increasing the end diastolic volume, or the max amount of blood in our ventricles after relaxation. We're also increasing the stroke volume because stroke volume is equal to end diastolic volume minus end systolic volume. And because stroke volume's a component of cardiac output, if we increase stroke volume, we're also increasing cardiac output. But when we're directly correlating end diastolic volume to stroke volume, that is the Frank-Starling relationship. Okay, the second thing that can affect stroke volume is contractility. So contractile strength at given muscle length, this is going to be independent of the stretch, and meaning it's also independent of the end diastolic volume. So increased contractility is going to lower the end systolic volume. So if we increase the amount at which we can contract the ventricle, that means the more blood we can push out of the ventricle, which means the less volume of blood that's left in the ventricle after contraction. And the end systolic volume is the amount of blood that's left in the ventricle after contraction. So in order to do this, we can have this occur if sympathetic epinephrine release stimulates increased calcium influx. More calcium into our cytoplasm is going to increase the contractility, because remember, calcium is our final trigger for contraction. If we're talking about cardiac muscle, they get it from two different places, the sarcoplasmic reticulum as well as from the extracellular space. The more calcium you have, the more cross-bridge formations you have, the stronger the contraction. Other things can also increase contractility. We call these things positive inotropic agents. So things like thyroxine, glucagon, epinephrine, we already talked about its effect, digitalis, and higher levels of extracellular calcium. Anything that's going to decrease the contractility of our cardiac muscle cell are considered negative inotropic agents. So something like acidosis, if we have too many hydrogen ions, if we have increased extracellular potassium, or if we're using calcium channel blockers, because then we're not allowing calcium to come into the cell. So here's just an illustration basically of what's going on when we're talking about calcium and how it can increase the rate, the force of contraction if we have more. So this is what we call a second messenger system. Again, maybe hopefully a review from A&P1. So our first messenger that's why it's called a second messenger, because you have two messengers, is norepinephrine. So norepinephrine is going to come in and bind to the beta-1 adrenergic receptor, because this is the receptor that's specifically on heart. So norepinephrine binds to the beta adrenergic receptor. This is going to cause our GDP, or GTP. GTP is similar to ATP, and then it's used as an energy source in our body. So we have GTP that comes in, causing this blue thing, which is called the G protein, to be able to translocate to a second protein, which in this case is an enzyme. So our G protein with our GTP bound to it is going to translocate from the beta-1 adrenergic receptor to the adenylate cyclase. Once we have the GDP G protein complex bound there, it's going to cause ATP to come in and be converted into CAMP. CAMP is cyclic AMP. So cyclic AMP is our second messenger. So it's going to go on and cause other things to happen. for example, like causing the activation of a protein kinase. A kinase is a generic term for a enzyme that phosphorylates something. So once we have an active kinase, that's exactly what it does. It phosphorylates something. But it's very important that it does this because one of the things that it phosphorylates are the calcium channels in our sarcoplasmic reticulum, as well as the calcium channels in our plasma membrane. So we have calcium coming in from the extracellular space along from our SR, that was our storage bank. Having all of this calcium influx is going to increase the amount of calcium that's bound to troponin, which is going to increase our cross bridge formation, which is going to increase our force of contraction. And all of this began because of norepinephrine. So we would say that norepinephrine is a positive inotropic agent. The last thing that can affect stroke volume is afterload. And afterload is the pressure that the ventricles must overcome to eject blood. So remember, our ventricles are pushing blood into our pulmonary trunk or our aorta. Well, there's pressures in our pulmonary trunk and our aorta, and the pressure in the ventricle has to be greater than those pressures in order to send the blood from the ventricles to through those blood vessels. So back pressure from arterial blood pushing on the SL valves is the major pressure. If we're talking about our aortic pressure, it's around 80 millimeters of mercury. Pulmonary trunk pressure is around 10 millimeters of mercury because remember, pulmonary circulation is a much lower pressure circuit, while our systemic circulation is a much higher pressure circuit. So hypertension, if you have really high blood pressure, this can increase your afterload, making it harder for your ventricles to push out blood. So what happens is because there's a higher pressure in your pulmonary trunk and your aorta, when our ventricles contract, it's not able to push as much blood out. If you can't push as much blood out because you have to overcome a higher pressure because you have hypertension, that means you're going to have more blood remaining in the ventricles after contraction. So this affects your end-systolic volume, and it's going to increase your end-systolic volume or the blood remaining in your ventricles after contraction. Because it increases your end-systolic volume, that's going to cause a lower stroke volume. Because remember, stroke volume is equal to end diastolic volume minus end stroke volume. So if we increase this one, we're increasing the amount that we have to deduct from our end diastolic volume, which is going to lower our stroke volume. Okay, if our stroke volume decreases as a result of decreased blood volume or a weakened heart, our cardiac output can be maintained by increasing our heart rate and contractility. So typically we have things that can go in and kind of counterbalance other things that are happening. For example, if something's happening with our heart, it's not as strong, it's not able to contract with as much force, or if we don't have enough blood entering for some reason, our body's going to try to compensate for that. So we call positive chronotropic factors. Those are going to increase your heart rate. So chrono means time, so now we're talking about the rate of something. Not tropic, it's chronotropic. And then we have negative chronotropic factors that are going to decrease your heart rate. So how do we regulate our heart rate? Our autonomic nervous system. Our autonomic nervous system is broken into two divisions. If you remember from AMP1, we have our parasympathetic and our sympathetic that are part of the autonomic. Chemicals can alter our heart rate and some other factors, all of which we're going to talk about. So first, let's talk about the autonomic nervous system's role on the regulation of heart rate. If we're talking about our sympathetic nervous system, this is our fight or flight division, and it's going to be activated by things if we're under some sort of emotional or physical stress. So when this happens, norepinephrine is going to be released. It's going to bind to that beta adrenergic receptor that we saw in the heart, and it's going to cause our pacemaker to fire more rapidly. If our pacemaker is firing more rapidly, so our SA node, that's going to increase our heart rate. If we increase our heart rate, that's going to cause our end diastolic volume to decrease because now we've reduced the time to allow the ventricles to fill. So again, if we have norepinephrine relief from our sympathetic nervous system, if we're in a fight or flight situation, it increases our heart rate, meaning our heart is beating much faster and pumping much faster, which means there's less time for it to fill. If there's less time for a ventricle to fill, then our max amount in our ventricles, which is our end diastolic volume, won't be as large. Increased contractility, so our end systolic volume is decreased because of the increased volume of blood ejected at the time. Because both our end diastolic volume and our end systolic volume decrease, our stroke volume can remain unchanged. Because remember, stroke volume is equal to end diastolic volume and N minus end systolic volume. If they both move in the same direction, if they both increase a little bit or if they both decrease a little bit, they really don't have an effect on the stroke volume because the stroke volume represents their difference. If we're moving both in the same direction, then our difference remains the same. If we're talking about a parasympathetic nervous system, that's our rest and digest division. So that's going to oppose the sympathetic effects that we just talked about. So that's going to be the role of acetylcholine. So acetylcholine causes hyperpolarization of pacemaker cells by opening potassium channels, which is going to slow our heart rate. If you remember what hyperpolarization is, it means that you're making the resting membrane potential more negative than it was to begin with. So if we're talking about a negative 90 millivolt resting membrane potential and having to go positive in order for an action potential, if we hyperpolarize it, instead of starting at negative 90, say we're starting at negative 140. So it's a lot harder for us to undergo that action potential if we have to start from a more negative resting membrane potential because we're in hyperpolarization. However, the parasympathetic nervous system doesn't really have any effect on the contractility of the heart itself. So heart at rest exhibits vagal tone. So the parasympathetic is the dominant influence on the heart rate. The dominant influence on our heart is actually inhibitory. So that's why parasympathetic is the dominant influence. So parasympathetic is going to cause a decreased rate of about 25 beats per minute. If for some reason we were to cut our vagal nerve, that's going to lead to a heart rate of about 100 beats per minute instead of the 75 beats per minute that we were expecting. When the sympathetic nervous system is activated, that's going to cause our parasympathetic nervous system to be inhibited and vice versa. So typically we only have one of the divisions of our autonomic nervous system having influence on our heart rate. We also have the atrial reflex. This is a sympathetic reflex that's initiated by increased venous return, hence increased atrial filling. So we have a ton of blood being returned to our atria. Because of this, we have so much blood in our atria, it's going to cause the walls of our atria to be stretched with increased volume. And if we have a huge amount of stretch or a huge amount of volume in our atria, that's going to stimulate our SA node to fire. If our SA node is firing, that's going to increase our heart rate. It's also going to stimulate receptors that are in the atria, that are stretch receptors, to activate sympathetic reflexes. So this is a really good flow chart here where you can go in and see how different things can affect our cardiac output that we talked about and what their effect is along the way. So if we're talking, when you go to study this, and I love these flow charts that your textbook includes, make sure you're taking a look at both. So if we're talking about changes in our autonomic nervous system, we're talking about changing the sympathetic or the parasympathetic activity. So if we increase our sympathetic activity or fight or flight, that's going to increase our heart rate. If we increase our heart rate, that increases our cardiac output. If we lower our parasympathetic activity, That's basically the same thing as increasing our sympathetic activity. So that's also going to cause an increase in heart rate and cardiac output. So even though you're studying this chart and you understand everything that causes the increase in cardiac output, I'd make sure you're aware that the opposite is true. So for example, if we decrease sympathetic activity, that would lower our heart rate and lower our cardiac output. So kind of make sure you understand things both ways, regardless of how these flow charts are set up. Okay, regulation of heart rate when we're talking about chemicals. So hormones are huge. When we hit chapter 16, which is the endocrine system, you get to learn a ton of hormones. But epinephrine is a hormone, and it's released from the adrenal medulla, which is considered a gland. So once we release the epinephrine from the adrenal medulla, that is going to cause an increase in both heart rate and contractility. We also have thyroxine, that causes an increased heart rate by enhancing the effects of norepinephrine and epinephrine. So it doesn't act directly on the heart, but it acts on another hormone that acts on the heart. Ions are going to play a huge role because our action potentials are the result of the shift of ions into and out of these cells. So if we're talking about their concentrations, that's going to affect their influx or their efflux. So intra and extracellular ion concentrations for things like sodium, which isn't listed here, calcium and potassium, they have to all be maintained in order for normal heart function. If we have imbalances, that can be pretty dangerous to the heart. Other factors can influence your heart rate. For example, your age. Typically, as you get older, your heart rate is going to get slower. So if we're talking about going from a fetus to a 90-year-old person, the fetus would have the highest heart rate and the elderly person would have the lowest heart rate. Gender also affects the heart rate. So females typically have a faster heart rate than males. So now if we're talking about the same age, so the elderly people, an elderly female would have a higher heart rate than an elderly male. Exercise is going to increase your heart rate. At rest, though, trained athletes can have a slower heart rate. Also, if we're talking about body temperature, if we're increasing our heart rate, we're also going to increase our body temperature, which you've probably noticed if you've exercised. Okay, congestive heart failure. This is a progressive condition where your cardiac output is so low that blood circulation is inadequate to meet the tissue's needs themselves. So what this is caused by is really an issue with your cardiac muscle cells themselves, so your myocardium. So if you have a really weak myocardium, this can cause congestive heart failure. So what can cause a weakened myocardium? Things like coronary atherosclerosis, so some buildup or clogged arteries. Typically, the buildup is the result of fat. And if we have this buildup in our blood vessels, that's going to impair the amount of oxygen that's actually being delivered to our cells. So our heart is going to become hypoxic, meaning it doesn't have as much oxygen as it should, and it's not going to contract efficiently because of this. So persistent high blood pressure. So you may have heard hypertension, which is high blood pressure, also referred to as the silent killer. It's a pretty serious condition. Persistent high blood pressure is defined by having an aortic pressure greater than 90 millimeters of mercury. And this is going to cause your myocardium to exert more force. So chronic increase in systolic volume causes the myocardium to hypertrophy, which means to become enlarged, and to become weak. So even though it's larger, you've weakened the cells. Multiple myocardial infarcts, so a succession of several heart attacks, that's going to depress the pumping efficiency because non-contractile scar tissue replaces those dead heart cells. We also have dilated cardiomyopathy, or DCM. This condition is defined by our ventricles stretching and becoming really, really flabby. So when they become flabby, that's indicating that the myocardium has kind of deteriorated. Not really sure why it happens. A lot of times they relate it to some sort of drug toxicity, or if you have some sort of chronic inflammation, but they're not 100% sure the exact reasons why it happens. Okay, congestive heart failure. So we can't forget that our heart is a double pump. So because it's a double pump, we can have conditions in which only one side of the pump actually fails. So each side can initially fail independently of the other. If our left side of our heart fails, then we're going to have pulmonary congestion. Because remember, our left atrium is receiving blood from our lungs. So if it's not pumping correctly, it's going to cause a backup to the blood vessels from our lungs and causing pulmonary congestion. If this happens, your right side continues to pump correctly, sending blood to the lungs, but the left side isn't able to get rid of the blood that's being returned. So what happens is your blood vessels in your lungs become like super engorged with blood. The pressure is going to increase, and sometimes we can even have fluid leak from these blood vessels into our lungs themselves. If that happens, that's actually going to cause pulmonary edema. The right side of the heart fails, then we have peripheral congestion. So what happens is our blood kind of remains in our body organs, and we have pooled fluids in the tissue spaces. And if we have a bunch of fluid in our tissue spaces, that's going to inhibit the ability of our cells to get the nutrients it needed from the blood. So the resulting edema typically occurs in your extremities, so places like your feet, your ankles, or your fingers. So if we have one side fail of our heart, that puts greater strain on the other side of the heart. And ultimately, if it's not corrected, your whole heart is actually going to fail. It leads to something called a decompensated heart. And if this happens, that means it's seriously weakened and it's irreparable. Like it's pretty much done. So treatment is normally directed towards removing any of the excess leak fluid or that edema by use of something called a diuretic. And diuretics usually are drugs that help increase the excretion of water, so increase urination or diuresis. The other treatment is aimed, or goal is to help reduce afterload using some drugs that help lower your blood pressure. And another option is to increase the contractility with something called digitalis derivatives, but we won't go there.